Hello, everyone. My name is Thuan. I'm a faculty in pediatric dentistry. As a part of the lecture series of course PD 190, I will present to you a lecture with the title Physical Assessment of Oral Cavity and Recognition of Anomalies, Common Anomalies. So the objective of this lecture is that you would be able to recognize and properly label oral anatomical sites, able to describe the location of soft tissue, dental lesion using the correct anatomical location, the lesion classification, the tooth name, and the surface label, recognize common pathology versus anomalies, okay, and the normal development. Before you see a child in a dental office, you need to master the knee-to-knee exam. This is the pictures that illustrate a knee-to-knee exam concept. You have a child with legs open and straddle against the waist of the parent, okay? And the knee of the provider, the dentist, have to touch the knees of the parent. And when you're ready, the child will lay down in a supine position, a flat position, asking the parent to secure the wrist of a child. Okay, the head of a child would be on the dentist's lap, and the dentist can very comfortable examine the oral cavity this way. Okay, the child may cry. This is important to inform the parents that, because this is a normal response for children under 3 to cry during a dental exam. Okay, let me go back one slide. Okay. So when you do a knee-to-knee clinical exam, what to look for is you're looking for normal anatomical landmark, such as lips, tongue, soft palate, hard palate. Okay, you're looking for teeth eruptions, any missing teeth. You're looking for any occlusal discrepancy, etc. You also look for soft tissue anomalies, dental structures and anomalies such as teeth. I mentioned that. Anomalies of structure and a number. We're looking for evidence of plaque and gingival inflammations. You're looking for stain and decay, okay, or caries. Lips. The lips form the entryway of the mouth, okay? The lip, also known as the labia. There are two different surfaces of the lips, the skin and the mucous membrane. Okay, the skin is the outside. Inside is the mucous membrane. Okay, the vermilion border is right here. Okay, and the following structure underline the epithelium of the skin of the lips. Okay, the vasculature, the sweat glands, salivary glands, also some hair follicles, most of the function to move the lips. Okay. The mucous membrane of the lips is known to be a non-keratinized tissue, okay, and they have a lot of capillary vessel close to the surface that give rise to the pink color, okay. The lips attach to the alveolar process, or the bone, by the frenum, okay. All right. It's important to examine the color of the lips, for example, for evidence of cyanosis, hepatic lesion, or trauma. Usually when a child have, let's say, congenital cardiac conditions, and they tend to be cyanosis, bluish, so it will reflect to the lips. Hepatic lesion is also a common finding among children, particular primary herpes. It could be very painful. Or evidence of trauma because they walk, they fall, etc. Let's go back. Also, when a child may have cleft lips and palate, this is a failure of development. Okay, when you have a mesial prominence that fused well together with the lateral prominence, and when the child have cleft lips and palate, maybe provided to fabricate an obturator that help with swallowing, eating, and they go to a series of surgical intervention with the idea is to help the child to have a closure of the opening and therefore develop proper phonetic early on. Okay, like the lips, the cheeks are muscle that cover with skin on the outside and mucous membrane on the inside. The examination of the oral mucus is very important in infant and toddler to assess the viral and bacterial infection. For example, this is the lesion of aphthous ulcer. This is another example of mucocele. Mucocele is like a mucus plug on the salivary gland. Okay, it's occur common among children. For the aphthous ulcer, is a cell-limiting lesion. It will disappear in perhaps 7 to 10 days. It could be painful, but it's self-limiting. For mucocele, it's relatively easy to remove. One can anesthetize at the base, use a scalpel to open up the envelope and excise the entire lesion. Make sure you put into a vial and send to pathology lab to confirm the diagnosis. Well, some children, particularly adolescents who chew tobacco, is also good to screen for oral cancer as well, particularly on the lower lips. Okay, this is an example of gingival inflammation of the gum. Okay, so the gingiva is the mucous membrane that covers the periodontal ligament, the alveolar socket, and the bone of the jaw. So the teeth will be positioned in a socket inside the bone, and they have a periodontal ligament attachment that connect the bone and the cementum layer. Examination of the gingiva help to review gingivitis, and a quick way to assess the gingivitis is use a toothbrush. If you brush the teeth and the gum bleeding upon brushing, that's a clear sign of gingivitis, because the healthy gum would not bleed when you brush. So would encourage the child or the parents continue to have proper oral hygiene with brushing, and if they can do that for 2 to 3 weeks or so, the gingiva will heal well. And when the gingiva heals, a healthy gingiva would not bleed upon brushing. Now, if gingivitis go untreated, it can get worse, and it can progress into bony involvement and result in periodontitis. Then, with a severe periodontitis, they can lead to tooth loss. Okay. This is an example of hepatic gingival stomatitis. Right? A hepatic lesion caused by viral infection. And these are virus in nature, so they will stay, usually they stay in the nerve ganglia and remain dormant when the child is healthy. However, when the immunity is being suppressed, this viral can be activated, and it's caused painful lesions. Sometimes fever can be associated with it. Luckily, it just is a self-limiting, so it come and go, and be patient. The lesion will take its course for about 7 to 10 days. Once in a while, you will see a child would have a very painful mouth, and they have a difficult time of eating and drinking. They can be dehydrated. In such scenario, the clinician could prescribe magic mouth rinse, perhaps, which tend to comprise of 2% viscous lidocaine, Benadryl, and calpactate. And we can use a Q-tip and apply, because kids, they do not know how to rinse and hold in place. They may end up swallow the whole content. So it's good to use the Q-tip applicator to apply, and that would help to treat palliatively, reduce the symptom of pain, and allow the child to eat and to drink so they can get better. These slides demonstrate marginal gingivitis, when you see black accumulate along the teeth here, and upon brushing they tend to bleed. Okay, this is a completely reversible condition, meaning that the child have to brush the teeth more carefully and properly to remove all the biofilm or the plaque that stick to the tooth surface. And over about 2 to 3 weeks or so, the gum will heal, to get better, become pink and form, and there's no bleeding upon brushing. This is close-up pictures demonstrate marginal gingivitis. Here is the example of streptococcal infection. Okay, usually occur but appear to be redness, little petechiae on the soft palate. It could involve the T and A tissue as well as the uvula. Okay, the palate is divided into a 2/3, the hard palate on the front, and then the 1/3, the soft palate in the posterior area. Okay. Okay. Now, the soft palate is mostly muscle, and it has an important role in swallowing and speech. The examination of the hard and soft palate may uncover thrush or Candida infection. Sometimes the child may have herb angina, which is caused by Coxsackie virus, and you may see petechiae, redness in the soft palate posterior area. Evidence of sexual abuse, trauma may also localize in the area in the soft palate in the back. So it's important to examine the soft palate. The normal hard palate consists of fusion of bone in the upper jaw and the palatine bone. Incomplete fusion would result in isolated cleft palate. And here is the example of isolated cleft palate. Incomplete fusion of the palate, and then you have a patent, the hole in the roof of the mouth. This poses a difficulty for a child to eat, and the food can spill throughout the nose. So it's good to obturate the hole by taking an impression, fabricate an obturator. That would be very helpful. Okay. And again, children usually go through a series of surgical procedures, initially with soft tissue surgery just to close the opening, allow eating, drinking, and develop proper phonetic early on. And later in life, perhaps about 10 years old, and they have a hard tissue surgery where the opening can be closed with bone graft. Here's another anomalies that's commonly found in an infant or a child mouth. They call Epstein purr. This little purr is formed due to epithelial rest. When the palatal shell fuse, the leading edge consists of epithelium, and some of this epithelial rest will develop into enamel-like mass material. If this little Epstein purr localized on alveolar ridge, we would call the bone nodule. They're very similar in structure and content. Okay, it's just different location. Now, the tongue is composed of entirely muscle and connective tissue, and it has the ventral and the dorsal surface. If an individual put the tip of the tongue to the roof of the mouth, okay, the ventral surface, the underside is smooth. Okay, the dorsal surface, the top, is most visible on the exam. The dorsal surface includes fungiform foliate circumvallate papilla, which are associated with the sense of taste. And the dorsal side of the tongue is also covered by a hair-like projection they call liliform papilla. The circumvallate papilla tend to localize at the posterior aspect of the tongue. Okay? Whereas the foliate papilla look like an ovoid, can localize along the lateral border of the tongue. Here's a picture demonstrate Candida albicans, or thrush, on the tongue of an infant. Now, try not to get confused between the discolorations, the white patches of the Candida albicans versus the milk stain. Okay, you can use the 2x2 gauze moist and you can wipe it off. If it's milk stain, you can remove it relatively easily versus if it were thrush. Now, if it is identified to be a Candida albicans infection, the treatment could be nystatin. Occasionally, we will see a child would have a tongue tie. It's quite common. The tongue tie is when you have a lingual frenum on the bottom of the tongue attached to the floor of the mouth. And does it have any implications? It does not seem to cause any phonetic problem, eating problems. However, the child may not be able to stick the tongue out, licking an ice cream cone later on in life, or it may interfere with breastfeeding. So if the decision is to release the tongue tie, the procedure can be very simple. We can anesthetize the bottom of the tongue on both sides, and you can use a scalpel or maybe a cautery to release the little membrane that attaches the tongue to the floor of the mouth. Well, the thick frenum that limit the movement that attach the tongue to the floor of the mouth is called the ankyloglossia. And again, it may inhibit breastfeeding. Okay, Phenectomy can be done to release the tongue, and I was described early on. Here demonstrates salivary glands. Inside the mouth, we have submandibular gland as well as parotid gland. Okay, the submandibular gland would empty into a duct they call Wharton duct, and parotid gland is on the upper area, right behind the second premolar, and they empty into a Stenson duct. Okay, now for patients that receive chemo treatment or radiation, they tend to cause hypertrophic of salivary gland, therefore reduce the salivary flow. And patients tend to have higher incidence of caries formation. The reason because the lack of salivary flow, lack of buffering capacity, therefore the oral environment tend to be more acidic. And once in a while, we're able to detect a obstruction in salivary flow due to calcification, they call salothyt, and it could cause inflammation, okay, inside the Wharton duct or Stenson duct. It could be painful. Now here demonstration of primary teeth. The primary teeth is named according to the nomenclature using alphabet letter. So letter A is used for upper right molar. Okay, letter A, that is second primary molar, and then B is the first primary molar, primary canine C, and you go across from upper right toward the upper left. D, E, F, G, H, I, and J. That's 10 primary teeth on top. Then you drop down on the bottom left, start with tooth number K, L, M, N, O, P. O, P is tooth central incisor. Q, R, primary canine, S, and T. Okay, there are 10 primary teeth on the bottom. So when a child have a full primary dentition, they have 20 primary teeth total. 2 on top, 10 on top, and 10 on the bottom. The primary teeth erupt around the age, the central incisor come in about the age of 6.5 months. And by the age of 2.5, the second primary molar also come in. Okay. Now, in primary dentition, the space between the teeth, they call interdental spacing or developmental spacing, they are highly desirable. The reason because the size of permanent teeth tend to be larger than the primary teeth, and therefore the space will accommodate. When a child has space between teeth, the future dentition, permanent teeth tend to be straight. When the primary teeth are well aligned and touch each other, there's a 85-86% chance or more that the future teeth will be crowded, and therefore may need an orthodontic intervention. Okay. For permanent dentition, the nomenclature is a little different than that of primary teeth. Now we use number to describe the name, each specific tooth. So we start on the upper right. Number 1 is for wisdom tooth. 2 is second permanent molar. 3 is first permanent molar. 4 is second premolar. 5 is for first premolar. 6 is canine. 7 lateral incisor. 8 central incisor. 9 also central incisor. This is upper right central incisor and upper left central incisor, 8 and 9 respectively, and so forth. The number continue 10, 11, 12, 13, 14, 15, and 16 is the upper left wisdom tooth or third molar. Then we drop down to the bottom left. It labeled as 17, 18, 19, 20, and move slowly all the way to the lower right and conclude at number 32, okay, which is another third molar. Now, a lot of patients tend to ask about the extraction of wisdom teeth. The wisdom teeth, when they erupt, and they erupt straight, and the patient has ability to clean it and take care of it without any recurrent pain, maybe the patient shouldn't have wisdom teeth extraction. However, if the wisdom teeth come in and it's impacted, it's difficult to take care, patients tend to have pericoronitis, repeated occurrence of pain, then maybe it's a good indication for wisdom teeth extraction. The idea of wisdom teeth eruptions cause the anterior crowding of upper and lower arch is a myth. It's not possible for a single tooth to push the entire segment of the anterior teeth together and cause crowding. Okay? So it's not true. So when an individual decides to take out wisdom teeth, namely number 4, 15, 17, and or 32, we have to establish a clear indication for doing so. In terms of tooth surfaces, the way we label tooth surfaces, the top, the chewing surfaces, is the occlusal surfaces. Okay? The facial surfaces is the surfaces that face toward the lip or buccal vestibule. The lingual is the surfaces face toward the tongue. The mesial is the surface that face toward anterior. And distal is the surface that face toward the back. Okay, here's the overall tooth anatomy. The tooth is comprised of 2 parts. The top is called a crown, and the bottom is a root. Okay, outside the tooth is covered by a layer called enamel. Enamel is made up of carbonate hydroxyapatite. This is 95% or more of ceramic material or hydroxyapatite. About 1 to 5% of protein and water in it. So the enamel can be very hard. Okay, the hardest substance known in the body. Inside enamel is dentin. Dentin contains hydroxyapatite, and I would say about 35% of proteins. And in it, they have dental tubules, and inside the tubules they have fluid. So when the fluid being disturbed, the patient may feel some sensitivity. So as a result, when enamel is wear down and exposed dentin, patients tend to feel sensitivity develop. Inside the tooth is a pulp tissue. Okay, it contains pulp tissue and it contains odontoblast. Odontoblast known to produce dentin over time, and when the odontoblast is being injured, they will produce repair the dentin. And also have vascular supply and nerve. The neurovascular bundle would come in the tooth at the bottom, the foramen, and keep the tooth healthy and vital over time. Okay. On the root surface is lined by a layer called cementum. And cementum is attached by periodontal ligament that connect the cementum layer with the alveolar bone. Now, for an individual that have periodontitis, they have bacteria inside the pocket, and these bacteria secrete enzyme, and enzyme is known to break down the periodontal ligament and establish a deep pocket. And over time, the tooth can be loosening and lost. okay, with bony destruction. So that would conclude the presentations on this topic. Thank you for your attention.